And as I say, today I'm going to be speaking to you about principles and approaches in primary and revision mastoidectomy. So I'm certainly not going to be covering today the anatomy and all of that because we all know you really need to go on a temporal bone course and then practice in real life, of course, to learn the intricacies of the anatomy. And I really don't think that's best learned through a slideshow. But what I'm going to talk about today is something about the approaches you might take in dealing with severe chronic middle ear disease. Certainly, I remember when I was a trainee, when I first started, otology was a bit of a dark science. It's still somewhat anecdotal, I would say, but at least if you've got some understanding of what are the pros and cons and debates about the approaches we might take, it might help you to understand what we're trying to achieve. So I'm going to start here by talking about a little bit about what the ear actually is and how it functions, and then move on to the sort of clinical approaches. So just a very brief overview of some of the physiology and pathology of the middle ear. So I always like to take us right back to evolution, actually, and the origin of the middle ear. So what we've got, of course, is a need to detect sound, a vibration, which for us, of course, is an airborne vibration, and the consequences and the advantages of that are obvious to us, really. Obviously, in many species, it's to help either detect or detect prey, or indeed escape from being prey yourself. But in humans, there's the additional benefit, of course, for language, which is, of course, a unique human characteristic. So if we go look at where exactly we're looking at, ultimately, we're trying to get it to an electrical processor, which for us, of course, is the brain. But the first electrical processor evolved 570 million years ago in this thing called a utilitarian. At least we think so. Obviously, it's not a fossilized record of when electrical processing started. And then there was something that developed in fish called osteocytes. These were cartilaginous fish, some of the very earliest fish before even bone was formed. And we can find remnants within the fossil record of a fluid-based detector of vibration. Now, essentially a cyst of fluid developed within the body of these creatures, and that allowed both detection in terms of vertical and horizontal plane, but also detection of vibrations coming from the water, which again would help to detect prey or escape being prey yourself, because even sharks are around at that sort of stage. And that is obviously represented now in a fluid-filled inner ear, containing both a partition for vestibular function and a partition for auditory function. And then actually the problem was that system really didn't work for when we became airborne. When we became terrestrial animals, sorry, that seems to be disappearing. We needed an ability to detect airborne sound, which doesn't really work with a fluid-based system. And so therefore, the Therapsids around 275 million years ago were some of the predecessors of mammals, and we developed an outpouching of the first pharyngeal pouch, which ascends up, stays connected to the pharynx in what is then to become the eustachian tube, and becomes this air-filled cavity within the skull, which obviously extends in the tympanic membrane and then further out into the mastoid air cell system. And that middle ear space has really evolved to allow us the ability to overcome the impedance mismatch between airborne sound, which is what we want to hear, suddenly having become well, not suddenly, 425 million years ago, become a terrestrial-based species using a fluid-based detector for sound. And that's what the middle ear space is there for. It's this outpouching of air. And in fact, it's evolved at least 5 different times in the fossil record, showing that multiple species that became airborne, terrestrial, required this facilitation of airborne sound. And in fact, 3 ossicles are only found in mammals. Other airborne, terrestrial creatures such as reptiles and birds have a single bone. So 3 bones is a characteristic of mammalian species. So just looking at this in a bit more detail, like I say, we've got this air-filled space within our skull, which includes, which we can call the middle ear cleft, and of course, it includes the eustachian tube, the tympanic cavity proper, and the extension of that as the mastoid air cell system through the antrum, and then the mastoid air cell system itself. And if we look at the function of that, we actually understand a lot more than perhaps the books would tell you, which are rather historic. This air-filled system actually has segregated function. And the posterior superior aspect of the middle ear, and indeed the whole lining of the mastoid, the epithelium is specialized for gaseous exchange. So although your books might say, oh, the eustachian tube ventilates the middle ear, actually it's far more complex than that. And if there's one thing you would take away from this, the idea that the eustachian tube causes all middle ear problems, it's just far more complex than that. We know that the posterior superior epithelium is a flat epithelium. It's very close to the venous system, and there's active gaseous exchange. That's been demonstrated. And actually that gaseous exchange is rather rapid, somewhat akin to the mucosa lining the lung epithelium. And then in the anterior inferior segment of the middle ear space, we have this special different epithelium, which has a mucociliary component, and that is designed effectively as immune function. It will clear out debris from this middle ear space, and that is normal of any air-filled space. You cannot have an air-filled space without some way of clearing out bacteria, other debris that may accumulate, because very rapidly it would become a problem. In fact, we know from embryological studies that these two parts of the middle ear are embryologically distinct and they fuse together. So you've got two distinct embryological and functional components to this middle ear space. You need an immune function to keep it clear, and you need a gaseous exchange to keep that full of air, because without air, you're not going to be able to hear airborne sound. So, to my mind, the main function of the eustachian tube actually is as an immune organ, where it allows this mucociliary clearance to pass down the eustachian tube and back into the pharynx to keep that space clear. And that is because we have a huge number of bacteria living within our nasopharynx. So if you look at the nasopharynx, it's probably between 2 and 6 million bacteria living within our nasopharynx. And so it's a somewhat Herculean task to keep that middle ear space free of inflammation and infection and subsequent inflammation. But it achieves it admirably most of the time. So, as we move now to thinking about pathology, we all know that you get acute mucosal inflammation. Of course, that's your acute otitis media, the most common bacterial infection in childhood, which will be seen in GP practices up and down the country, as well as many that obviously don't present. So that may manifest as acute otitis media, and also may manifest as effusion, such as glue ear, which most glue ear, of course, is short-lived, disappears, and it's only those cases that persist that we see it. But 95% of the time after you get an acute otitis media, there is a middle ear effusion. It's just very short-lived, and we don't see that. Then we can get this transition to chronic mucosal inflammation. We don't really understand what leads to that chronicity. It may be due to persisting low levels of bacteria. It may be due to host genetic factors. And I won't bore you with all of the details. That's what my PhD was on. But there's certainly a very strong heritable risk to a risk of getting otitis media. And this sort of ear disease is definitely run in some families. And that may manifest as persistent effusion, persistent glue ear, of course, that which we see, and associated low pressure. And we might talk about, oh, it's the eustachian tube. It's probably just as likely to be poor mucosal gas exchange across that middle ear mucosa, as I've mentioned. And then we may, with persistent chronic inflammation, get damage to surrounding structures. So that may include a tympanic perforation. In fact, most patients who present with chronic suppurative otitis media, the pus just discharging out of the ear, they don't give you a history, oh, my eardrum ruptured. They just present with a discharging ear. And probably we think it's persistent inflammation in the middle ear space eventually leads to lysis and eventual perforation of the tympanic membrane, which allows bacterial ingress from outside. You may also get lysis leading to weakening of the tympanic membrane, which, when accompanied by low middle ear pressure, and again, we could argue what causes the low middle ear pressure, leads to retraction. Of course, there can be damage to the ossicles, particularly the long process of the incus, presumed to be because of a tenuous blood supply, and you get a sequelae erosion. And of course, you may get an abnormal biology of the tympanic membrane, again, for reasons that are not clear. In some patients that have persistent inflammation, almost every patient who gets cholesteatoma has had glue ear in the past. Some persistent inflammation leads to some malformation of the normal biology of the tympanic membrane, meaning that the the squamous epithelium of the tympanic membrane grows inwards. And there's all these theories of cholesteatoma formation. Actually, I think we need to get rid of those because it's been clearly shown on electron micrographic studies that you actually get an active ingrowth of the epithelium from the squamous layer into the middle ear space. So it's a biological process. It's not simply something sucking in. There's a biological active ingrowth of epithelium. And what we need to understand in the future is what's causing that. So that's just to give you some background. Now, acute mucosal inflammation is easy because although it causes a lot of disease, it resolves, it will go away. We don't need to worry about certainly long-term consequences, not to belittle the pain and discomfort it can cause to a lot of children. When you damage the surrounding structures, we often indicate surgery to repair the perforation, possibly to sort of strengthen the tympanic retraction if it's causing problems, to fix the ossicular erosion, to excise the cholesteatoma. And actually, that's easy. But the thing in the middle, the chronic mucosal inflammation, is the thing that surgery cannot treat. And that's just something to keep in mind as we're going through this, is what we're trying to do with mastoid surgery, of course, is repair the damage to the surrounding structures, but the underlying biology cannot necessarily, of course, be changed by what we do. So just moving on to some of the clinical aspects, what are the indications and what sort of planning might you do for mastoidectomy? And just to talk you through some of these things, and I'm sure some of you are already aware and may have read through this in the books. So why might we do a mastoidectomy? I mean, the obvious choice and the most common reason I would do a mastoidectomy is, of course, for cholesteatoma, that squamous ingrowth. And there's only one treatment for it, really, if you want to effect cure, and that, of course, is surgery. We may also do it for chronic granulomatous mastoiditis. Not seen as commonly, but is seen. And I've had a few cases of this where actually even granulomatous disease without cholesteatoma can cause significant erosion. I've had a couple of cases just in the last year with presenting with intracerebellar abscesses and temporal lobe abscess due to chronic granulomatous disease. You go into the mastoid and what you find is just this horrible granular disease without cholesteatoma that has eroded huge amounts of bone. Actually, they're really horrible to deal with because this stuff really bleeds. You may develop it for acute mastoiditis, and there is debate about how far and how extensive you need to do your mastoidectomy. Some people say, oh, well, just simply incising a subperiosteal abscess is enough. Other people say taking off the cortex is enough. I think most otologists would say, well, why not go all the way down to the antrum? If you're experienced, that's a relatively easy thing to do. And then you know that the whole middle ear cleft space is linked up and drained. And then you may do a mastoidectomy, of course, for access for things such as auditory implants, middle ear implants. You may need to approach inner ear pathology in the vestibular schwannoma or cochlear implant, of course. You may need to operate on other things as well, such as a tegment and semicircular canals. There's also this idea that it can act as an adjunct to tympanoplasty. So in some cases, you may wish to perform a mastoidectomy in addition to tympanoplasty. We only have retrospective data on that, and the retrospective data do not show any real evidence of benefit from this approach, but I'm not saying it's wrong. It may be that in certain cases, certainly mastoidectomy does seem to help with the success of tympanoplasty. We just don't have evidence that that is truly the case. So I'm going to concentrate really on cholesteatoma surgery because it's the most common indication for mastoidectomy. So what are the aims of cholesteatoma surgery? This is what I actually tell my patients. There are three aims, and in this order. First of all, is to give you a safe ear. That means that the cholesteatoma is removed. There is no residual and no recurrence. So again, people may be aware, but we need to differentiate between residual disease, that is disease that is left behind. Obviously, I would hope that it's microscopic disease that wasn't visible. And then there's recurrent disease. Recurrent disease is when the cholesteatoma forms again anew. So the two differences between residual disease and recurrent disease. We're aiming for a dry ear. A dry ear is obviously one that does not discharge, and that's important. Patients who have a wet ear really hate it and poor quality of life. So what that means is that if certainly, for example, if you've got a mastoid cavity, it needs to be accessible so that it can be cleared out, and there should be no exposed mucosa. So we know that, externally, all of our body is lined with squamous epithelium, which is designed to be rugged and exposed to the external environment and survives very well. But mucosa on the outside is never happy. It will weep. And we want, ideally, a hearing ear. So that means to achieve a hearing ear, you need ossicular continuity. So you need something linking the tympanic membrane to the oval window. It doesn't have to be 3 ossicles. It can be anything that's linking the two. And you also need a ventilated middle ear. So that means air around that, the ossicles or the ossicular reconstruction that allows it to vibrate. So those are the aims of mastoid surgery. But yeah, we don't always achieve all of those. Particularly the hearing can be difficult. So in terms of thinking about before the operation, what might we do? We might need preoperative imaging, and there's debate. You may help with surgical planning. So preoperative imaging may help to identify the degree of mastoid pneumatization. It may also identify, for example, a low-lying dura. Of course, the dura is the roof of the middle ear space. It may also help to identify complications. So it may identify that there's bony erosion of the lateral semicircular canals, and you may get a fistula lateral semicircular canal, which warns you of the potential risk of a dead ear and helps you to counsel the patient as to that risk. It may warn you that there's a dehiscent facial nerve, that the facial nerve also hasn't got a bony covering, and then again warns you of that possibility. What I would say is don't ever use imaging really to diagnose cholesteatoma. The diagnosis is clinical. You see it when you look inside. It's not to help you identify, because a pacification on the CT in the mastoid doesn't tell you it's cholesteatoma. It just tells you there's something there. It could be thickened mucosa, it could be fluid, it could be cholesteatoma. Bony erosion makes it slightly more likely it's cholesteatoma, but again, you can get bony erosion from a retraction. So you really need to diagnose cholesteatoma clinically and not the scan. So I don't scan until I've already listed the patient for surgery, and then I scan because I think it is helpful. And the reasons I scan, so some do consider it superfluous in routine mastoidectomy, but the reason to scan is for the reasons that I've identified above. And for me, it's really, in my view, it's about helping surgical planning, particularly for the mastoid pneumatization. So you may say, well, it helps you to identify lateral semicircular canal fistula. I would say assume there's a lateral semicircular canal fistula and warn your patient of a risk of dead ear, regardless of what you're doing. People may say it's a dehiscent facial, it tells you there's a dehiscent facial nerve. Just assume there's a dehiscent facial nerve and warn your patient of the risk of facial weakness, because it can happen in any mastoidectomy. I have actually operated without a CT scan. So when I worked in Cambodia, we didn't have, well, we had a CT scan, but it cost $80, which just wasn't economically beneficial. So I operated for many, many months without a CT scan. And actually, once you're used to operating that way, you do start to think, well, why do I actually need it? It should be performed, I think, if you've got any question of craniofacial malformation. For example, you don't know, the facial nerve could be in an aberrant position. And obviously a facial palsy following mastoidectomy is a disaster, and you should be forewarned of that. So I think it's pretty much mandatory if you've got a child or even an adult with craniofacial malformation that you're going to operate on. It should also be performed for congenital cholesteatoma, so that rarer variant, which is congenital, probably due to epithelial trapping during embryology within the middle ear space, because you can't tell how far it is. And I've actually been caught out. 1 or 2 congenital cholesteatomas are bigger than you think, and I've certainly found myself in the petrous apex of a child, not expecting it to be quite so deep. So these can be quite extensive. And again, it just gives you a little bit of warning as to how far you're going to go to help with surgical planning, and also to counsel as to potential risks. So this is just talking about why I think CTs can be used useful. Really, for me, it's about the mastoid pneumatization. So in the middle here, you've got average pneumatization. So, you've got a nice honeycomb structure. There's this antrum here you can see leading into the middle ear space. This is as you would see on a CT scan. But sometimes you're lucky and it's hypopneumatized, which is this image on the left-hand side. And, it's beautifully aerated, and that just makes life a bit easier. It's not unusual, however, to find the one on the right-hand side, which is hypopneumatized, sometimes also called sclerotic. And that is a bit more difficult. And unfortunately, hypopneumatized mastoids are also associated with a greater risk of middle ear disease. So it's not unusual to find yourself drilling into a hypopneumatized mastoid, which is also disease. And this makes mastoidectomy one of the fun operations. So this is just to illustrate particularly the risks of hypopneumatize. So for example, if you're drilling here, you might suddenly find, as you see on the left here, oh, there's not a lot of air cells here. That sigmoid sinus at the posterior aspect is actually quite forward, is restricting my access. And maybe the dura is lying a bit low as well in this poorly pneumatized mastoid, or sometimes even a well pneumatized mastoid, the dura can lie low. It's going to prevent access up here to get into particularly the epitympanum, the attic area above the middle ear space. So that's just something to be aware of. The hypopneumatized mastoid, it helps me to plan. Why? Well, let's look at these two CT scans. So these are very different mastoids. On the left, you've got a hypopneumatized, very well pneumatized mastoid. This would be a dream to drill into. I don't often see these sorts of mastoids in the chronic ears that I deal with. So if I was looking to get into the middle ear space underneath the tympanic membrane, here you can see the malleus, and the tympanic membrane is here. I've got so much space. If I drill all this out, I can see beautifully into the middle ear space. And I can go beyond. I can go see into the anterior, what's called a protympanum, and into even the eustachian tube. Or if I was in a slice a little bit more superior to this, I'd be able to see into the anterior epitympanum, the anterior attic area, quite easily, because there's just a huge viewing angle. If you compare with the sclerotic mastoid, what would I have to do? I'd have to drill through a whole load of very thick bone before I even get to anything representing an antrum. And the angle you can see is far less conducive to seeing into the anterior part of that middle ear space. So this just makes things much more difficult. The sigmoid sinus, as you can see, is more anterior, and that's quite common in a hypopneumatized or sometimes called sclerotic mastoid. And this one isn't even as bad. I've operated on some that are much, much worse, where the sigmoid sinus is really protruding forward. There's hardly any bone here. And then you're looking at this sort of angle, even further around, which makes that access much more difficult. And that actually, for me, may determine the approach you use. So there are two different approaches. You might do a wall up or a wall down approach. And that all comes down to whether you are preserving the posterior ear canal wall or taking it down. Now, if I've got a well pneumatized mastoid, actually the posterior, the canal wall up approach is actually relatively easy, because I can access into the mastoid and I can also access into the epitympanum and all those spaces and get good visualization. If you've got a sclerotic mastoid, as shown on the right, it's much more difficult to do that because of the angles, because you have to drill through difficult bone. There's no problem with drilling through difficult bone. You just have to be patient, and it takes a long time, but you get there. But the difficulty is the angle, really. I'm not going to see as well. So there's a different approach, which is actually saying, let's do a wall down approach, where actually I take this posterior wall of the ear canal away. And as I do, I can access into this space. And actually, even if I create what's called a mastoid cavity by taking this away, I'm going to end up with a very small mastoid cavity, because there is no big mastoid air cell system to create a huge cavity. So for me, if you've got a sclerotic mastoid, I would certainly consider the wall down approach, both because it makes my life easier and also because they're going to end up with a cavity that is very unlikely to be big or cause problems. Facial nerve monitoring is also standard as part of your approach, but value of that is uncertain where anatomy is normal. And I would encourage you never to rely on the facial nerve monitor. You really need to know your anatomy. And again, in Cambodia, having worked there for 5 months without a facial nerve monitor, it's fine. What I would also say is I've definitely been dissecting cholesteatoma off a dehiscent facial nerve, very extensively stimulating the facial nerve as I'm doing that, and the facial nerve monitor says nothing. So it doesn't tell you for certain that you're on the facial nerve, and that's why I think you need to be cautious that it's going to give you the magic answer. It can be useful for revision surgery, particularly where you're going in and there may be scar tissue stuck to a dehiscent facial nerve. It may give you that slight warning earlier than you would think, or maybe I'm on the facial nerve. Or again, in craniofacial malformation, where the facial nerve may not be in an obvious anatomical location. Again, in both circumstances, you should proceed with caution and not rely on the monitor. Think of it as an adjunct. So, thinking about the actual surgery, exposure, there's different approaches. You can occasionally get to a cholesteatoma just through the ear. So you can lift up the tympanic membrane, and occasionally there are small cholesteatomas that are just there. And I've done a few just down the ear canal, actually, permeatal, just a small cholesteatoma, and remove it. More often, you need to make an incision. One incision is what's called the endaural, and there we're actually going through the anterior, well, we're splitting effectively the pinna. So this approach is to pull the pinna back. We need to get the pinna out of the way of the mastoid. You can either pull it back or you can push it forward. The endaural is a way to push it back. So you make an incision between the tragus and the root of the helix, which is a natural embryological cleavage point. And you can come between those two cartilages and pull the soft tissue posteriorly, and you get exposure of the mastoid bone. I increasingly actually use this approach because I think it leaves you with quite a nice scar. It's very well hidden, and you get reasonably good access. However, the difficulty is it's not so easy to reach the mastoid tip. So if you don't know that a cholesteatoma is limited, and to be honest, you don't often know that it is limited, you can find yourself struggling if it's a very extensive cholesteatoma, because getting down to this mastoid tip here can be difficult through the endaural approach. The other approach is postauricular, and that is obviously going behind the pinna, lifting it forward and lifting all the soft tissue forward, which gives you excellent exposure of the mastoid, but leaves you with a slightly less pleasant scar. There are people who argue who worries about the scar really when you're doing this sort of surgery. But I would say I was fortunate, and I've been trained to do both approaches, and I use whichever I think is the minimum required, but sufficient to get access to the mastoid in that particular case. So, in talking about removal of disease, I've already mentioned wall up versus wall down approaches. So, the wall up approach is basically preserving that posterior ear canal wall. And the idea is that afterwards, you restore what is effectively a normal looking ear without a mastoid cavity. And I'll come on to talk to you about the mastoid cavity and the pros and cons of that later on. So, like I say, I'm not going to go through the actual anatomy, because I think you need to learn that through temporal bone courses and through actual rehearsal on patients, of course. But suffice to say that I think is a two-stage approach to mastoidectomy. There's removing the lateral part, and there you're looking out for example, the sigmoid sinus, the tegmen at the roof of the ear canal, and preserving that posterior canal wall. So you're creating this sort of almost kidney-shaped cavity to get in, and you take that down until you get to sometimes there's often something called Kerner's septum, which is a suture line between the petrous and squamous portions of the tympanic bone, which lies just lateral to the antrum. And sometimes that's very well formed, and you actually have a sheet of bone there. And then you go through that and you reach that antrum, and then you're in the deeper part of the dissection. And I think that's the second stage of the dissection, where you need to identify things such as the lateral semicircular canal, which I'm sure many of you are aware is a key landmark for orientating other structures within the middle ear space. So the idea is you've preserved that posterior ear canal. You can see here, this is actually a very well-developed mastoidectomy. The tegmen, the roof of the midley on the right here is well exposed. The sigmoid sinus has also been exposed. You don't necessarily need to expose the sigmoid sinus because it depends on where your cholesteatoma is. So here on the right is an example of a cholesteatoma. I mean, this has been, if this was indeed the size of the cholesteatoma, the mastoid cavity is actually bigger than it needs to be, of course. You only need to open until you reach the edge of the cholesteatoma and you're able to remove all of it safely. It depends on what it's wrapped around. It's not unusual to remove the ossicles. Very, very common to remove the ossicles. Often the ossicles are eroded. It's normal for the long process of the incus to be eroded by the time you get to surgery or even by the time of diagnosis, really. So it's not unusual to remove the ossicles. And that should be done in any case where the ossicles may be impeding your ability to remove the cholesteatoma. Occasionally, I can preserve an incus that's intact, but that's unusual. Usually you have to remove it to make sure you get the cholesteatoma because it's usually wrapped around. Now, the difficulties with the wall-up approach are actually access. So it looks great, but there are two areas where access may be difficult. First of all, this straight arrow here is the anterior epitympanum, or the epitympanum generally. So the superior ear canal, which you've preserved here, can make this space very, very tight. It can make it very difficult to see into this space, particularly if the mastoid is not as well pneumatized. This posterior part can be quite forward, very difficult to get into this area, and that may be an area in the anterior attic, the anterior epitympanum, where you could leave some residual cholesteatoma. The other place that is quite difficult to see, particularly with the wall-up approach, but even with the wall-down approach, is this area called the sinus tympani. So that is an area deep. Some of you will be au fait with the middle ear anatomy. The facial nerve is running around this corner here, and the sinus tympani is, if you like, medial to that space. And that's a very difficult area to see. But having a canal wall in the way there doesn't help. A wall down approach does help a little in visualizing that area. So the main disadvantage surgically at the time of operation with the wall up approach is your inability to access some slightly difficult areas. And if we look at residual disease, so that is tiny bits of cholesteatoma left behind. When you look, go to assist surgery, so that you can look into the sinus tympani. I just use a 0-degree endoscope. You can look into the anterior epitympanum if it's difficult. Usually you can see it, but occasionally I do use an endoscope to look into that area and make sure I've got everything visible out. You can also use laser painting. So you use a defocus beam. So that area of the mastoid where you've taken everything out is you just paint it with a defocus beam of laser, and that's thought to denature any remaining cholesteatoma epithelium and has been shown in studies to reduce the risk of residual disease, which presents later on. So the alternative is this wall down approach. The wall down approach is basically following the disease from its start backwards. There's actually different ways to do it, but I always do what's called a front to back approach. You start at the disease and you drill and drill and drill until you get to the edge of the disease. Depending on how much you drill, we might call this an atticotomy. That's where the attic, the epitympanum, is exposed and the disease is removed and the area is reconstructed. Or it may extend into the antrum, that sort of big air cell, linking that middle ear space to the mastoid, and we call it an attico-antrostomy. Or you may need to go further back because the cholesteatoma is more extensive, and then you created a mastoidectomy, which should be wall down. They haven't actually taken the wall down here, but you would do as part of your completion of the mastoidectomy. So this is a mastoidectomy completed where that wall has been removed. Here, they've still got the ossicles in place. It's actually very, very rare for you to be able to leave the ossicles in place when you do a wall down mastoidectomy. So usually the incus and the head of the malleus is removed as part of this process. So just to talk briefly about complications of mastoidectomy, what might happen, you might expose some dura. If you expose a little bit of dura, it's not actually a problem. If it's a small area, you can just leave it. You may get some bleeding that can usually be stopped by pressure, occasionally a bit of light bipolar diathermy I've used, and that's fine. If you get a CSF leak, you'll need to repair that, and you may be able to repair that just by putting fascia over it and reducing the pressure, or occasionally you may need to put a piece of cartilage through it, almost like a butterfly graft, if any of you know what that is, with a bit of fascia on one side and cartilage on the other to basically make a plug for that hole. And then you would cover that area with bone pate. So you take some bone dust, fix it, and cover it, and that will hopefully stop any problems. Sigmoid sinus bleeding, I've had a couple of these. It bleeds a lot, but it's a low pressure system. Usually, if you press on it, it will stop. If it doesn't, then occasionally you can actually put some absorbent gel foam or something of that kind, some collagen based products um, above and below the site of bleeding, here and here. Pack it very densely, and that will put pressure on that vein and stop the bleeding coming from that central portion. There's no real evidence to support you need to put the head up, head down, any of that. It's bleeding out. Air is not going to go in. It's just blood is going to come out. So I don't think you need to worry about whether you put the head up or head down, which is sometimes in the books. Lateral canal fistulas, you may encounter these. So that's where the lateral semicircular canal has eroded. That's the most common canal to erode. And the risk there is if the perilymph within the mid-inner ear space leaks out, you've got a risk of a dead ear, 1 in 6 chance of a dead ear if there is a lateral canal fistula. So you just need to be cautious. So normally what you do is you leave the matrix of the cholesteatoma, so the outer lining of the cholesteatoma, over the lateral canal until the end of the procedure, because if there is a problem, you want to be ready to deal with it. Here we are gently dissecting. Oh, there is a fistula underneath, gently dissecting with a pledget to remove it. And if you do get a leakage of fluid from inside, the key thing is not to suck it, because if you suck all the perilymph out, we think you're much more likely to get a dead ear. And if you've got a fistula, you just cover it. You can cover it with bone pate and with fascia. And I've certainly had a few of these, and actually they're usually okay if you cover them up. You don't get a dead ear necessarily. Facial nerve injury, probably the most feared risk, and the classic place they say is around this area, just below. You're basically drilling the ear canal, and you haven't found the lateral canal adequately, and you may accidentally drill into the facial nerve, not having seen how deep you are with the facial nerve coming around this corner. Not a good thing. So they say if there's a partial injury, so around 1/3 or less of the facial nerve injured, it's going to bruise, it's going to swell. You can release the perineurium to allow for some of that swelling to take place, but there's probably nothing more to do. Don't try and repair it, because you're not going to get a better outcome from repairing it. If it's more severe injury, and there's complete transection, then you probably should graft it. Whether or not you'd be in a good state of mind to graft it yourself, or whether you call someone else in to do that, either at the time of the operation or even the next day, would be okay. Certainly wouldn't leave it too long. And then you can graft it by taking a nerve graft, for example, from the great auricular nerve in the neck, and stitching it. You need to cut the two ends to make them clean ends, and then stitch with microscopic sutures, probably 6 or 7 to join these the nerves together to provide a tract for it to grow back. At the best, they say you get a grade 3 palsy if you're lucky. So in terms of the mastoid, there's reconstruction as well. So once you've done your mastoid cavity, you need to smooth it out to make sure there's no sort of bony ridges. You need to lower what's called the facial ridge. The facial ridge is actually a misnomer. It's actually the external auditory canal. So the facial nerve runs here just behind the external auditory canal, and the facial ridge is actually the external auditory canal. People sometimes leave that high. I don't know why. Maybe it's because they're worried about drilling into the facial nerve, but actually it's a mistake, because if you leave that high, that facial ridge, you end up with a big lump in the middle of your cavity, which seems to cause problems with wax getting trapped. So it's critical when you do a mastoid cavity to lower this down. If you're drilling in the line of the facial and you've seen the position of the facial, you should not be drilling into the facial. So, you should be confident to do that. Some people also talk about amputating the tip of the mastoid here if you've got a very big cavity, because the idea is the muscle then falls in and automatically reduces the size of the cavity. And then the reconstruction, this is the point when you're actually quite tired, you've done a lot of the cholesteatoma dissection and you're just wanting to get out, but actually this reconstruction is critical. So you're going to reconstruct the drum and line the cavity with squamous epithelium, or you're going to encourage squamous regrowth. Compared to the old-fashioned radical mastoidectomy, the radical mastoidectomy, there's basically no attempt at reconstruction. The whole thing was left open to basically weep and discharge forever, so that if any cholesteatoma came back, it would just come out. but you leave people with a horrible smelly ear. So I don't think anyone now will try to do a radical mastoidectomy. We do a modified radical, which is where you're trying to reconstruct. So I think it's really critical to cover all of the mucosa, potential mucosally lined surface of the mastoid with fascia. You need huge amounts of fascia. You need to stick it down. The fascia is going to disintegrate over about 6 weeks. But the idea is if you've got a tiny bit of squamous epithelium left from the tympanic membrane, it will slowly grow over all this area. And hopefully it will win the race to cover all of this area, not the mucosa underneath that can pop out. We don't want any mucosa exposed if you've done a wall down mastoidectomy. The other approach that's increasingly being used is primary obliteration. So some people are actually taking bone pate and using that bone pate to actually fill up this mastoid cavity again, and that's falling more and more popular. And I've started to do that with some of my cavities as well. The idea is that the risk of residual disease with that is actually very low. But the problem is, if you do get residual disease in this mass of bone that you've reconstructed, it can be difficult to excise that. You also need to do a meatoplasty, so you need to widen the ear canal, and that's to allow access into the mastoid cavity. There's many different approaches. I personally don't make it anything more complicated than cutting a bit here, cutting a bit here, taking out the cartilage, sticking that skin flap back. For me, that seems to work very well, and you get a nice big meatoplasty. So, should you attempt a ossicular reconstruction? This is debated. So, as I already mentioned, success is related to ossicular continuity. You want the ossicles to be joined up to the tympanic membrane or the oval window at less. Ventilation, you need air around that space, and the height of your reconstruction needs to be close to what it should be. You shouldn't have the tympanic membrane stretched too much. So you can try ossiculoplasty at the first operation. The problem is there's quite a lot of inflammation. And so what might happen is you do your beautiful ossicular reconstruction. For example, here is a partial ossicular reconstruction onto the stapes head. And then a year down the line, you've got all this fibrosis. You've got the tympanic membrane that is retracted down because the middle ear ventilation isn't so good, probably as a result of poor middle ear mucosal gas exchange. And so your prosthesis is sitting too high and it's surrounded by scar tissue. You may end up with a bad result. And actually the results, the data suggests that probably primary ossiculoplasty is associated with poorer hearing results than delayed ossiculoplasty. So this is what I often do if I've done an operation. I actually just put some cartilage under the tympanic membrane, and then I wait and see. Often the incus is gone, and you wait and see. And it might be that in a year, actually the middle ear doesn't heal so well. It retracts back down. The cartilage then suddenly sits on the stapes, and you've got ossicular continuity. And these patients actually end up with very good results. And I've had many mastoids where I've just done that, leave it alone, and it retracts back down. It retracts down because of bad disease, and you end up with a very good hearing result. And it's great. Obviously, if it retracts beyond that and you get total collapse of the middle ear space, they're not going to have a good hearing result. But the alternative is that at 1 year, there is no or minimal retraction. And if that's the case, then you naturally know the height of the tympanic membrane, and I can go and put in now the perfect size ossicular reconstruction to get hopefully a good result. So for me, I think if you can, a staged ossiculoplasty is better. So there's all these other ideas, or could you also add grommets? Could you do posterior tympanotomies, anterior tympanotomies, the space anterior to the malleus to get more air in? Could you do eustachian tube dilation to get more air in? Actually, we have no evidence that that's going to affect long-term outcomes from mastoid surgery. So thinking about follow-up now, residual disease in wall up is actually around 26% of meta-analyses at 1 year. So actually a quarter of your patients with wall up will end up with residual disease. That's despite everything you've done. And that's from the best surgeons in the world. Your risk of otorrhea ear discharge is actually quite low. I can't remember the last, if I've ever had a wall up approach end up with a discharging ear. And there is a small chance of recurrence. So it's about 10%, 7 to 8%, sorry, at 5 years. That means the tympanic membrane retracts again and you get a new cholesteatoma. So you're back where you started. So what you need to do is, if there's residual disease, you may need second look surgery. So that means going back in at around 12 months to see if there's any disease left back. Possibly that's preferable in young children because their cholesteatomas grow quite fast. The alternative now is sequential diffusion weighted MRI, which can pick up some of these with significant sensitivity and specificity, but not 100% certain, and unreliable for small cholesteatomas. However, some of these grow very slowly. So if you're going to do that, you need to image probably at 1 year, and then probably again at least at 2 to 3 years. Some people are saying even imaging at 5 years, because some can be missed at 2 to 3 years. If you've got residual disease, you can excise it, and you then can need to consider whether further imaging or surgery is required. If it's a small residual, you may be able to do this endoscopically, as shown here. It often shows up as a little white pearl. Or if it's really, really persistent, you may need to consider the wall down approach, because the wall down approach is actually associated with very little, much reduced risk of residual disease. Some papers quote 17%. I think it's much, much less than that, because if you do get residual disease within a mastoid cavity, you can normally just suck it out in clinic. However, around a third of patients end up with a discharging cavity because that reconstruction just didn't work. And I don't know if that's poor technique or just bad luck. It may be intermittent or frequent and continuous. And if it's frequent and continuous, these patients really are fed up with it. Wax can also trap in this ear, and we don't fully understand that. This is a study showing the movement of wax out of a mastoid cavity. It can go all over the place, so we don't really understand it. And if you look at the visits of patients since surgery, the number of ears, mastoid cavities that settle slowly grows up. So at 10 months in surgery, it's about 40% of cavities have settled, but actually at about 40 to 50 months in surgery, around 70% have settled. But this belies some realities. So this is a paper which looked at these mastoid cavities, and some of them settle and then start to cause problems again. And some of them causing lots of problems, and then suddenly they settle. So they go between the two. Cavity that's settled, even for a few years, can cause problems later on. So comparing wall up and wall down, there's big debates about this. Wall up approach, the ear ends up self-cleaning. But there's an increased risk of inaccessible residual disease, and there's a risk of recurrent disease. That's where the cholesteatoma reforms. With wall down, there's a very low risk of recurrent or residual disease. If the tympanic membrane retracts again, actually, it's got nowhere to retract to. It just retracts onto the mastoid cavity, and that's the end of the problem. You don't get a cholesteatoma forming again. But the ear often needs clearing. There's a risk of chronic otorrhea, and a sequelae reconstruction can be difficult. Some patients also have a sensitivity to imbalance, for example, when cold air gets in, because the lateral semicircular canal is very exposed within the mastoid cavity. So I'm going to finish now by talking about the discharging mastoid cavity. So you've got this cavity that's causing problems. What else can you do with that? Causes and solutions. There may be residual recurrent cholesteatoma that can certainly occur, and then you try and excise that. It may be that there's exposed mucosa and inflamed lining, and then you would need to excise that and regraft with, for example, fascia, with the idea that it will reheal with squamous epithelium. There may be some entrapment because you've got tortuous anatomy. Either you've got a small meatus, you didn't do a meatoplasty adequately, or the previous surgeon didn't, or you've got a high facial ridge, that posterior canal that was not taken down, or the cavity just wasn't smooth. So you may need to do meatoplasty and refashion the cavity. This is what people were doing, but I think increasingly, and I myself would now move towards obliteration of a discharging cavity, which is associated with more than 90% success, and I would concur with that. And so by obliteration, it means removing the cavity. Now, traditional approaches to do that involve various flaps. You could do a muscle flap, superiorly based, and bring it in. You could do an inferiorly based muscle flap and bring that in as well. But I think more and more, and certainly from my money, I would use bone now. So you take off bone, you carve off this bone, and you pack it. You must pack it really tightly into that mastoid cavity, because it will otherwise shrink. And you pack it and you pack it and make it really, really tight. And then you end up with this cavity and you cover it. And the reason I think it works so well is, even if you've got a little bit of mucosa that was in the mastoid cavity that you didn't remove, actually, if you stick bone all over it, it has very little chance of coming out into your reconstructed ear canal. So I think it's a really good operation. And I've done a handful of these, but so far, every single one has ended up with a dry ear, and they've been delighted. So to summarize, the choice of technique in mastoidectomy should be selected on anatomical, patient, and surgeon factors, which approach you use, which exposure you use, whether you do a wall up or wall down approach. And you may choose a wall down approach, for example, if you want a patient that's not to come back for another operation. It's a single operation. Good surgical technique and adjuncts mean that a safe and a dry ear should be achieved in almost all cases of primary or revision mastoidectomy. A safe ear is an absolute must. I always say a dry ear is a wet ear is a failure. I certainly would aim for a dry ear in every single mastoid that I do, and I would do a revision until a patient ends up with a dry ear. The hearing is more difficult because the sequelae reconstruction can be difficult and that ventilation can be difficult. And the reason the ventilation is difficult is probably related to middle ear mucosal gas exchange, because you've got a chronically inflamed mucosa. You're not going to fix that with surgery. And if it's very badly inflamed, it's going to retract and your sequelae reconstruction just isn't going to work. So I never make any promises with hearing outcomes in mastoid surgery. I think the future actually would be to examine approaches to preserve, repair or restore function to middle ear mucosa. I think there's some interesting things that we could do in trying to grow middle ear mucosa, transplant it into the middle ear space and see if it actually helps restore function, particularly with regards to ventilation and the consequent effects on hearing. Thank you for your time, and I'll stop there.
Great. That was absolutely amazing. Thank you so much, Prof. Bhutta. I think that was doing exactly what it said on the tin. I thought it was great, and I particularly liked all the first principles that I think a lot of our trainee colleagues will appreciate. From even thinking about things like why we choose a certain approach and what the first principles are behind that particular approach. I do have some questions. Hopefully, you've still got time for those. So I'll just I'll put those through to you. First one's kind of interesting. One is about is there anything regarding the new understanding around cholesteatoma pathophysiology? So this idea of the eustachian tube, the organ of respiratory or immune function, that can help predict or lead us towards thinking about risk for recurrence as opposed to the residual, obviously, but actually recurrent disease.
So no, we don't have any good way of predicting the outcomes of this, unfortunately. So we do know, like I say, it's what we do know is that retrospective analyses have shown that I think 95% of patients who get cholesteatoma have had previous grommets. We also know that the number of grommets that they've had and the duration of glue ear predicts the risk of cholesteatoma. And I think all of those are just actual markers of chronic middle ear inflammation. Can we predict on an individual basis who's going to get who's going to get recurrent disease? No, we don't really know. And I have to say, I've operated on some cholesteatomas where you think, oh, that was very small, that looks fine, I take it out. And then you see them a year later, the eardrum's completely retracted, looks horrible. And I've operated on some cholesteatomas where it's horrendously diseased mucosa, really, really horrible, extensive cholesteatoma. You take it away, and a year later, the eardrum looks normal. So I just don't understand it.
Okay, there's another question for research then. There's a question that are mainly about your practice or guidance about practice. So we've got one about UK practice or trend in UK practice. This is from a consultant colleague who says they don't use CT scans unless they feel this is a complicated ear or complicated disease pattern. However, there is a school of thought that in this day and age and in a first world country like the UK, everybody should have a CT scan from a medical legal point of view. They asked about your opinion on that. And I'm going to follow that on with regards to facial nerve monitoring. Similarly, from a medical legal point of view, should you be using it all the time? And somebody else has raised, if the point is to use facial nerve monitoring only in complex ears or you know, you mentioned the syndromic or those kind of ears, then actually should people be using it in all ears so that they're used to it? I was just wondering what the question is for you to answer what your opinion is and what your practice is around that.
So one of my colleagues doesn't always CT scan, particularly for the children, because you know it's radiation dose. It is sometimes a general anesthetic to give them, because if they're very young, they might not sit still. I have to say I do routinely CT scan because I think it helps me to plan the wall up versus wall down in the way that I've said for pneumatization. I do always use a facial nerve monitor because medico-legally, I think if you didn't and you had a facial palsy or you had some other complication where you had a big CSF leak or a facial nerve injury and you didn't have those to hand, I think it just makes it more difficult to defend. That's not to say that you can't do it. If you feel comfortable being able to defend what you've done, that's absolutely fine. I've had a facial nerve monitor that stopped working in the middle of the operation. I just carried on.
That. Yeah.
And I've also had patients who've turned up without a CT scan for whatever reason. I've just documented it and carried on because I feel confident that I can go ahead. So I would say some of the older surgeons are used to not having a CT scan and just going ahead. And I think most of the younger surgeons would routinely get a CT scan because it's normal practice. But I think you can do what you want as long as you're prepared to justify it. Like I said, in Cambodia, I've worked without a facial nerve monitor, without a CT scan. I didn't find any of them made any difference, actually. And I think I ended up a better surgeon because you have to concentrate on what you're doing.
Sure. I can only imagine the impact of that training by fire almost in that scenario. We've had a question about what is the least, I guess, degree of mastoidectomy that can be done as an adjunct in tympanoplasty for chronic mucosal otitis media. So I think this is from the principle of achieving the safe ear. What is the least mastoidectomy? I wonder if they're talking about what you were talking about, whether there were options of atticotomy to attico-antrostomy with a sequelae. I think that's maybe what they're getting at.
So is this for cholesteatoma or for a tympanic perforation? What was the question?
For cholesteatoma, for chronic mucosal otitis media. So I'm presuming in the march from a chronic effusion to a cholesteatoma.
So let's differentiate. So with cholesteatoma, you've kind of got to get to the disease.
Yeah.
Now, so I suppose the other reason to get a CT scan is occasionally I find actually there's only a pacification. I know there's a cholesteatoma because I've diagnosed that clinically. And occasionally on a CT scan, I see, oh, there's just a little bit of pacification in the epitympanum, the attic, and the rest of it's clear. So I know the cholesteatoma can only be at most in the epitympanum. It can't be in the mastoid. Now, if the mastoid is all opacified, it doesn't tell you the cholesteatoma is filling all of it because it might just be full of fluid. In those cases, I would do an endaural and an atticotomy. I mean, some people do it all down the canal. I think a small endaural just makes your life easier. Some people use endoscopes and so on. I personally think endoscopes for some areas are very useful, but I don't use them for the whole operation. But if I know that it's limited, then I would do an atticotomy because an atticotomy tends to heal very well and you've got the disease out without doing the whole thing. Usually you just don't know how extensive it is. So quite often you go into the mastoid and you find it. And most surgeons would just go, we'll open up the mastoid and we'll see what we find. Yeah. And a big cholesteatoma actually doesn't take much longer than a small cholesteatoma. What slows you down is when it's stuck to the facial nerve, when it's stuck to the stapes. That's where
the disease pattern, isn't it?
Yeah.
Yeah.
Okay. Cholesteatoma disease, sorry, I was just going to mention that's controversial as to whether you do a mastoidectomy. So that's a different question.
Thank you. We're approaching 9 o'clock, so I don't want to keep you too long, but I've just got 2 more questions related to obliteration, really. The first one is, you mentioned about your practice that you've now started to do primary obliterations of the mastoid cavity. What is your sort of process or your diagnostic workup or decision making when you decide which cases you are going to do a primary obliteration in? How do you make that decision?
So it's a little bit, sort of judgment on the day, as it were. I think there are some people who are now doing primary obliteration for everything. And I think actually, having looked at the evidence, that's a reasonable approach because actually your risk of residual disease is much lower. I don't think you remove the disease anymore when you're doing a bone obliteration, but probably the bone itself just stops that cholesteatoma growing. But there's definitely around 5% of cases where the cholesteatoma grows within the bone. So that's difficult. Where I've used it most is probably where I've got, so, as I mentioned, if it's limited to the attic, you can actually do an atticotomy. You can remove that. And that's quite easy to reconstruct with some cartilage to reconstruct that attic area. If I've done however, there's some cases where you've got attico-antrostomy. So it's not fully into the mastoid, but it's into the antrum. Now I can take that out and I check that I'm happy that I've removed everything and I'll laser paint that area. And I go, okay, that's been removed and I'm pretty confident. Then if I've done a front to back approach, so I've created an attico-antrostomy, I might just bony obliterate the antrum. So they haven't effectively got a cavity. They've just got an atticotomy because that will heal very, very well. And normally, if you've just got an atticotomy, for some reason, wax never gets trapped and it's just like a normal ear. So those are the indications I'm using, but I'm increasingly convinced by the possibility of bony obliteration for all mastoidectomies. What I don't know is we don't really understand the hearing outcomes from that. So although there's been reviews of it, it definitely seems to reduce the risk of residual disease, but I don't know if the hearing outcomes are affected. I'm slightly worried that by obliterating all that mucosa, actually you stop mid-ear ventilation, and that might affect your ossicular reconstruction. Maybe I'm just being overcautious, and maybe I should just forget about the hearing. But sometimes when you're in a kid, you think, actually, this is them for the rest of their life. If I bone obliterate, that's it. I'm never going to get that mucosa back again. There's a little bit of work from a guy called Takahashi in Japan. He showed in small series that the more mucosa you preserve in the mastoid, the greater the chance of getting mid-ear ventilation. So who knows?
Oh, that's really interesting. No, that's a really interesting little bit of extra stuff for us to look up. I'm going to make this the last question, if that's okay, Prof. We've got a question about in that scenario, perhaps, or even in a revision mastoid that's discharging, if you're going to do an obliteration and it's a large mastoid cavity. You did slightly touch upon the use of fascia and other materials, but there's a question about what can you use if there's a very big cavity and you don't have enough bone, and also what is your preference if bone isn't available for obliterating a mastoid cavity. I've seen the flaps, the muscle flaps myself. They seem to give reasonable outcomes, but what's your sort of preference?
I've used muscle flaps when I was training. I don't really use them now. I think the problem with the muscle flap I find is it's difficult to predict how much shrinkage you're going to get. The muscle is definitely going to atrophy because it's not going to be used. So it's going to shrink back down. Therefore, your cavity is not going to end up exactly as you wanted. I mean, people do get good results, and that's fine. I think you can always get bone. You've got the whole skull. So all you need to do is extend the incision a bit. You can go right up there. I've been right up here, almost, almost at the vertex of the skull, just drilling off, drilling off, drilling off. You just got to be patient. You can always get bone. You've got the whole skull there on that whole side if you need. Don't go into the orbit, but anywhere else around there, you can get plenty of bone. It takes time. I've definitely, in places like Cambodia where you've got huge cavities, yes, it's a bit tiresome. But the thing with the bone is it's really important when you do it to compact it. So I made this mistake when I started as a consultant. I wasn't compacting it enough, and then it shrinks, and then you end up with a small cavity. Actually, they ended up fine anyway. They were dry, but if you compact it really hard as you're packing, keep packing, keep packing, keep packing, what you end up with is that bony line. And where that bony line is, you're almost going to get, a little bit of shrinkage, but that is where your ear canal is going to be. Do a big wide meatoplasty as well, if that hasn't already been done. And you basically end up, after a revision mastoid obliteration, with a dry ear, with a slightly wide ear canal, and that's it. And the patients are happy. Yeah.
Very nice. Having said the last question, I've got one last half question, if that's okay. Yeah, any synthetic or industry-based things that can be used alongside bone patty or independent of the bone dust that you've gathered?
Yeah, of course. I mean, there's various granules. I don't use those. You probably, maybe your colleagues are aware of the issues we had with Serenosem, which was some years ago, which was a granule that was created, borrowed from orthopedics. Actually, it was found 10 years later to cause massive problems. There was huge bony erosion caused by the actual granules, causing technical problems. Personally, I always try to use biological, your own tissue, really. There's also something called biodesign, which you might be aware of as a scaffold of decellularized collagen. I think it's of pork origin, which you can use. I've used that once because this was a patient who'd had 5 previous mastoidectomies, not by me, but by someone else. And there was just no fascia around. Although you can even use fascia lata. I've once harvested that from the leg. So you've got other options, but I've used biodesign once. I don't routinely use it because I know of colleagues who've had problems with granulation tissue related to that. So wherever you can, natural is best.
Brilliant. Well, all it remains for me is to say thank you again so much for your time, and particularly for sharing your experience. What a treat for all of us to hear your own experiences and what you've done and giving us some pointers.